Let's talk about a very interesting infection. It is pneumonia, infection of the lungs. We have so many patients because of pneumonia in our hospitals, and we classify pneumonia based on the place where the infection has taken place. If it is outside the hospital, it's community acquired pneumonia. If it is in the hospital, the patient is more than 48 hours in the hospital, then it's nosocomial pneumonia. And there's pneumonia in the case of patients who are immune compromised, and there we should take really care of the patients who are immune compromised, what kind of chemotherapy or under what kind of immunosuppressive the patients are under. Based on that, we have to choose the antibiotics. So far, case of CAP, community acquired pneumonia by immune suppressed patients, for example, we categorize the infection in light, middle, and high infections based on the condition of the patient, the mortality rate based on the diseases what the patient have, like comorbidity. If the patient has cardiac diseases, if the patient has high oxygen need, then it's middle sphere, that's middle. And if the patient is hypertensive, if there is the patient is not in the normal mental state and need vasopressor, then, or even need the assistance in the breathing with high flow or even CPAP, or need to be intubated, and it's the high severe pneumonia. Even in case of severity by immune compromised patients, we have to consider the other parameters like neutropenia. In this case, we have to consider the pathogens like Pseudomonas, Astronophobus, Multifida, Enterobacteria, and even by calcineurin inhibitors, the patient, if they are under cyclosporine or tacrolimus, then we have to consider the infection with Legionellas or even Aspergillus, and the mycotical infections or even the viral infections. We have to cover all these kind of pathogens if we are beginning a therapy. And based on the clinical condition, radiological imaging like CT scan, we also it is also recommended to do the bronchoscopy and take the BAL lavage and look for the pathogens through PCRs, for CMV, EMV, tuberculosis, Pneumocystis cerevisiae, promycocytitis. And there's a special case if we have two pathogens like atypical pneumonia. There's the infection of CMV and also Pneumocystis cerevisiae pneumonitis. And in that case, we have to differentiate and indicate and begin the therapy, like for CMV with ganciclovir, like 5 milligram per the weight of the patient, and is also based on the EGFR. And on the other hand, in case of Pneumocystis cerevisiae pneumonitis, we have to do the diagnosis through after bronchoscopy. PCR is not specific in that case. We have to do the diagnosis from the secrete what we gain from the bronchial secretions through the bronchoalveolar lavage, and the diagnosis is in the Grocott Farbone or immunofluorescence. At the same time, parallel, we can also go for PCR and beta-glucone, but it is not so specific. And the therapy is with cotrimoxazole. Well, I have experienced in my job once a patient with HIV. He also had the Pneumocystis cerevisiae pneumonitis. and his initial symptom was pneumonia, but he was so immune compromised, so we just diagnosed for HIV, and it was also positive. So we have to look for the patients if they have any kind of immune suppressed disease, if we have this pneumocystis pneumonia, because they are opportunistic infections. A small aspect for the aspergillus infection in the lungs, and who are the risk patients, the patients who are neutropenic, who are immune compromised, like leukemia patients or AIDS patients, and who are under corticosteroid therapy, or who are under immune suppressive TNF alpha inhibitor, or even the patients who are chronic and the chronic sick people who have like cystic fibrosis, protestantian sarcoidosis, and even the ICU patients. And therapy, which is recommended from the guidelines, according to the guidelines, voriconazole. Here it is important to look for the time for the drugs. We have to see how much drug is in the blood. We have to test after we begin the therapy, so that it does not cause the it does not overdose based on the GFR. At the other side, we have to also look for the interactions, and the other combination is other option is amphotericin B, 5 to 10 milligram per kilogram carbohydrate, or even casfofungin. Sometimes you can combine voriconazole and casfofungin. And we just talked about so much of the infections, and here is the conclusion. Before beginning of the antibiotics, it's always recommended to take blood cultures, and after beginning the antibiotics therapy, after 2 to 3 days, we have to take the blood culture to see if our therapy is helping the patient, if there are even bacterias in the blood culture. So we have to escalate, de-escalate based on the clinical condition and blood culture. Apart from that, meropenem, it is also reserved antibiotics like linezolid and tigecycline and Unacid and cefuroxime. They are not so recommended because they are oral antibiotics, because they are not so good reserved in the gastrointestinal tract. On the other hand, if we have staphylococcus aureus infections, then antibiotics is at least for 2 weeks intravenous is recommended, and even echocardiography or transesophageal echocardiography to just rule out endocarditis. And by candida infections, 2 weeks fungal therapy is intravenous recommended, and even echo is recommended. Apart from that, enterococcus and candida, if they are in urine, we can ignore them, but we also, based on the clinical condition, we can even take the sample again, and if they're older people and if they are symptomatic, then we have to begin the therapy by enterococcus in blood. We have to even look for the focus. And apart from that, if there are catheters which may be the source of infection, then they should be taken out from the body. And apart from that, we have to think critically if we have bacterial URI, so that we have to ask the patient if they are really symptomatic, and see if they have fever to begin the therapy. And sometimes the leukocytes and nitrate, we can even ignore them if the patient do not have symptoms. Like for a woman, they are normally positive but they're asymptomatic. In that case, you just don't begin the antibiotic therapy. It should all be based on the clinical condition and the patient's history. So this was a small highlight on the anti-infect therapy, which I have learned through my work and through all the Fortbildungs and through all the lectures what I've heard from the various institution, and I'm just taking this as a source for preparing for the examination also.